Dr. Davidson is currently working as the medical director of endocrinology and nutrition and diabetes for Virtual Medical Group. She is a practicing endocrinologist and physician at Virtual Endocrinology in Voorhees. Dr. Davidson graduated from UMDNJ/Rowan SOM in 2003, completed her internal medicine residency at Rowan University SOM in 2005, went on to do and complete her endocrinology and metabolism at Rowan SOM in 2008. She's currently board certified in internal medicine, endocrinology, and metabolism. Dr. Davis is also has an endocrine certification in head and neck ultrasound, and she does these procedures. She's also capable of doing needle-directed biopsies under ultrasound guidance. We're getting her connected to her lanyard as we speak. And please help me welcome Dr. Davidson.
The remote.
The remote. I believe that this is, I think, is this the remote here?
Okay.
Green button.
This one or that one?
I believe it's this one.
Got it. Thank you.
Thank you.
Well, thank you for having me. I actually wanted to do a really practical lecture regarding diabetes because there are plenty of algorithms out there that are available to follow, but there are so many nuances with our patients, with the side effects of medication, and with the cost of medications that really prevent multiple barriers to managing our diabetic population outside of just being able to follow an algorithm. So, I wanted to approach this in a case-based fashion where I keep flipping up the case and then talking about, well, what as an endocrinologist would I choose and why would I choose that and what am I thinking about when I choose that. So outside of what you can all read on the multitude of guidelines from the ADA or the American Academy of Clinical Endocrinologists, the Endocrine Society, this is really, well, what do we do in the field every day with all the practical realities that we face? So, why is this important? There are currently 11.3% of the US population with diabetes. If you look at statistics, though, this is going to progress and continue to increase. If you look here right now, that 38% of the adult population has prediabetes. There are some studies that have predicted that it is possible that by the year 2050, the number of people with diabetes could be as high as 30%. Well, so for those of you who refer to endocrinology, you know how long it takes you to get your patients in to see us. So if you sort of see where we're going, there are certainly not going to be enough growth within the field of endocrinology to handle these. So at the end of the day, who's handling this? Primary care is handling this. In some cases, cardiology is participating, nephrology is participating. So we have, a lot of, education. I think interesting to me is that, 11% of the population has diabetes, 38% has prediabetes. And endocrinology is not a required rotation in medical school. It's not a required rotation in some residencies. And I actually do teach the family practice residents at Virtua. It was not a required rotation until a few of the residents had started rotating with us and said, why is this not a required rotation? So again, looking at prevalence increasing to 33% by the year 2050. And then middle ground scenario somewhere between 25 and 28%. And that's overt diabetes. That doesn't even include prediabetes. So this truly is a public health crisis. So I'm just going to jump right into a case. So a 47-year-old, this is a common scenario for you, past medical history, hypertension, hyperlipidemia, Type 2 diabetes, metformin, you've started that already, 1,000 milligrams twice a day. They're on their ACE inhibitor and their high-intensity statin therapy. The A1C is 8.5%. So what do you choose next? And I used to say when I was teaching the fellows that, there's not a wrong way to go about doing this, but there are some better ways than others. So what do we have to think about when we are seeing this patient? So we look at, first of all, let's talk about metformin, biguanides. What are our pros? So the average A1C reduction with a biguanide is approximately 1.5%. That's pretty good. Understand that most studies, because I'm going to give you average A1C reductions for all of these medications, and it is super helpful to know that. But most of the studies done are done with people who have A1Cs somewhere in the 8 to 9 range. The higher the A1C, the actual better reduction you're going to get in A1C with these agents. So you may have a patient who has an A1C of 9.5, and you might see a 2% reduction in A1C from that agent. It's inexpensive, right? In the world of prior authorizations, high-cost medication, you can get this still free at ShopRite, although I think they make you now, they used to make you come in every month. I think now it's like some of the ShopRites make you come in every 2 weeks to pick it up, so that's kind of a pain in the butt. So I think a lot of people would rather pay their $10 for their 90 days and be done with it. Weight loss, we still see weight loss with metformin. It's modest, but at the end of the day, when a lot of these patients are presenting to you, we just had a discussion about obesity. They did such a fantastic job about talking about how many of our medications cause weight gain. This is still inexpensive first line. This has also been shown in diabetes prevention program to delay progression of diabetes, and the reason is because of the fact that it is offloading the work of the pancreas. It is decreasing hepatic gluconeogenesis, which then ultimately allows for the pancreas to work less, and so you can delay progression of the disease. Also, I didn't put it on here, but another big pro is no risk of hypoglycemia. So, if you have that patient who walks into your office and they are, talking about, they're drinking soda and they're eating a lot of sweets and they're eating a lot of carbs and there's a ton of dietary movement, with an A1C that's running in the 8s, most of the time we're not going to just go to lifestyle changes alone at that point. We're still going to start them on metformin, but you can start them on metformin knowing that if they make dramatic lifestyle changes in their first 3 to 6 months, you don't have to be concerned about hypoglycemia. So mechanism of action, decreases hepatic gluconeogenesis and increases sensitivity. True mechanism of that is not completely understood. For those of you who are visual learners, these types of things give me a headache, but if you are a visual learner and love graphs, this is just how metformin works and how it decreases hepatic gluconeogenesis. I'm not going to go through that. What are the cons? So the side effects, lots of diarrhea, bloating, gas. As far as how I advise my patients initially is I do tell them that although it doesn't have to be taken with food, they should really start taking it with breakfast and dinner till they know how they tolerate it. And if they are able to tolerate it with food, that if it's more convenient for them to say take their metformin at bedtime without food, that's actually okay to do. So you have to decrease the dose in chronic kidney disease. So we reduce the dose by 50% if they have a GFR between 30 and 59% and discontinue below 30%. And again, that is due to the risk of lactic acidosis that occurs. All right, so back to the case. The A1C is 8.5. What should we add? So what do we have to consider? We have to consider what's the cost. What is the patient's financial situation? This is a conversation that I'm sure you guys are having every day because for these patients, they are often on multiple medications. And as Dr. Godleski helpfully pointed out to me at lunch, when it comes to prior authing medications, I only have to worry about the diabetes meds, but you guys have to worry about their migraine meds and all the other things that you have to worry about. Side effects, what other medical conditions do this patient have? What side effects have they had with other medications in the past that might make you consider choices? Compliance, a patient who is working, shift work may have a harder time dosing something 2 or 3 times a day. Patients just may not want to take things 2 or 3 times a day. What are their comorbid conditions? And what is the average A1C reduction that you are looking for? What you may pick, if I had picked this case to have an A1C of 7.5 versus 8.5, would potentially be different in terms of how strong the agent is. So back to our case. So I'm going to give you a little more information. So now this patient has an AST of 64, an ALT of 55. Dr. Kolnick, I see you nodding over there. Fibrosis score of F2 with moderate fibrosis. What am I going to pick to help Dr. Kolnick out here? I'm going to pick a GLP analog. Why? Because the GLP analogs can reduce your A1C between 0.78 and 1.9%. So again, we're starting at 8.5. I've got a decent chance of getting this patient to goal with this medication. No hypoglycemia risk. It's, in terms of the different available forms, there are once weekly injections, there are once daily injections, and then our Rybelsus is our daily tablet. Weight loss can average between 3 and 5.5 pounds when using these. Some of the studies, again, are more aggressive than that, depending on the agent that you're choosing. So if you look again at semaglutide, the weight loss with that is more significant. And again, the GLPs, most importantly, and where my mentality was when I chose this drug, was there's evidence of reversing fibrosis and inflammation associated with non-alcoholic fatty liver disease. I will present, a multitude of cases, but I'll also throw in some patient experiences. I have a young woman who has metabolic syndrome, diabetes, who presented to me and was seeing liver specialists who had LFTs that were in the 300s. So of course, liver specialist was ruling out other causes besides fatty liver disease, and everything was negative. So I put her on semaglutide. In 3 months, her LFTs were completely normal. Completely normal. So, the GLPs also have evidence of reducing cardiovascular risk. Okay, we're all talking about the SGLT2s and heart failure and cardiovascular risk, but an approximate 15% reduction of both cardiovascular events as well as stroke with a GLP. There's also some evidence of renal protection as well with our GLPs in addition to the cardiovascular risk. And again, on the renal protective side, presumably that's due to decreased microalbuminuria, and again, about a 15% decrease in rate of progression. So just if you're interested in some of the bigger trials, I did not list all of them. There are many, but the SUSTAIN trial specifically looked at the cardiovascular risks. The LEADER trial also looking at cardiovascular risks and showing decrease, non-fatal MI, non-fatal stroke, as well as decreasing mortality. So again, if you're a visual learner, these are all the different areas in which GLPs act and what they're doing. So we have a lot of different, you can also see, and this is sort of past the scope of what I wanted to talk about today, but you also see GLP in bones. There's a lot of discussion about how many of these diabetes medications may impact bone health and increase fracture risk. And I will say that while the data still is becoming a little bit more clear, it still remains a very muddy area. So when I'm choosing a diabetes medicine today, bone health and the patient's bone health isn't really my top priority as far as choices go. And again, just another graph in terms of increasing lipolysis and tumor necrosis factor alpha, IL-6, adiponectin, so all the different mechanisms of action. And I agree with my prior colleagues that the GLPs, from an endocrinology standpoint, we have long-standingly suspected a central effect, as well as delayed gastric emptying. All right, so what's the downside? I put up there number one, cost, and it's a combination of what the out-of-pocket cost is, as well as the prior authorization process. You have an onerous process. I mean, how many times do you get the letter that says, well, they have to have tried metformin and Actos, metformin and glyburide, and failed all of those before I'm going to let you have this, right? We have, an easier time, I think, in endocrinology to be able to support the fact that I can say that I am submitting data to show that this patient has fibrosis. Here's the study that shows reversal of fibrosis with this agent that hasn't been shown with my glipizide, and can often get through the prior authorization process. The harder piece of the puzzle sometimes then still becomes what's the out-of-pocket cost for the patient. Nausea, vomiting, abdominal pain. So this is a significant side effect. But this is the fun stuff. So what about the risk of pancreatitis, right? I mean, these medicines cause pancreatitis. Well, the reality is actually diabetics, type 2 diabetics, have a higher risk of pancreatitis than the average population. When these studies were initially done, there seemed to maybe be an increased risk due to the medications. But if you look at post-market analysis and studies, there is not a statistically significant increase in pancreatitis in patients on a GLP above and beyond what the type 2 diabetic increased risk is. So a patient who has a history of recurrent pancreatitis, you might consider being cautious with the choice, but a patient who has a history of gallstone pancreatitis, I'm still going to use a GLP agent in that patient. And thank you for agreeing with me there, Dr. Kolnick. So what about the risk of medullary thyroid cancer? So, when the GLPs came out, there was a black box warning about medullary thyroid cancer. And the reason for that is that rats, where these were studied, have a lot of GLP receptors on their C cells. So the GLP stimulates the C cells, which increases cyclic AMP and then causes increased risk in calcitonin. And that's where we saw an increased risk in rats. In humans, we do not have receptors on our C cells for GLPs. So frankly, as endocrinologists, we don't feel that this warning is appropriate. And it really just scares patients. And really, now, that being said, if I have a patient who has MEN2, I'm not going to put them on a GLP. If they have a history of medullary thyroid cancer, I'm not going to put them on a GLP. But outside of that, I have patients that I see for papillary thyroid cancer. So I'm putting them on the GLP, and they're saying to me, oh, I can't take this. It says I have, a risk of thyroid cancer. So I always say to them, rats have increased risk of medullary thyroid cancer because of GLP receptors on C cells. Humans do not have those receptors. And so there really has not been any significant reports in humans. Do these need renal dose adjustment? So you just heard me talk about the fact that they're actually renally protective, but do you need to renally adjust the medication? So not necessarily, but what I would tell you is that as you increase and titrate dosing, because most of our GLP analogs require dose titration, they will have decreased clearance of the medication and may have increased side effects of the medication. So you may consider a slower titration or simply have a conversation that they are at increased risk for side effects from this medication. I have used these safely in patients with end-stage renal disease on dialysis, but they have definitely needed lower dosing and have not tolerated the higher dosing of side effects when they have chronic kidney disease that's more severe and significant. And then what about a GLP in cirrhosis? So is that safe? And the answer is, and that'll apply to metformin as well, which I didn't talk about, but yes, both safe in those cases, but since in both cases these medications decrease hepatic gluconeogenesis, you do have an increased risk of hypoglycemia in meds that otherwise would not cause hypoglycemia if you are using them in cirrhosis. All right, back to our case. Okay, patient can't afford it. They have a high deductible plan. Now what are you going to do? Same situation. So a TZD, that's our next step. Why? So a TZD, also an excellent agent in terms of lowering A1C. Average A1C is about 1.5%. It is inexpensive. No hypoglycemia, a once-a-day pill. also been shown even more significantly to delay progression of diabetes. When you look at the diabetes prevention program, that particular study used a TZD that is no longer available on the market, but nonetheless, so it showed an even more significant delay of progression to diabetes from prediabetes with a TZD than with metformin. This has also been shown to reverse inflammation and fibrosis in non-alcoholic fatty liver disease. Now, is this showing as significant of a reduction in that as the GLPs? No, but there's still benefits. It's a good addition for your low BMI patients, right? You all have those. So, you know, I always say that diabetes is like it's like a spectrum disease. You have people on one side of the spectrum who all of their disease is genetically driven, and you have the other side of the spectrum where there's still a genetic component, but it really is predominantly lifestyle that's leading to that and everything in between. So, you know, I have multiple Asian populations. You know, I joke I have a nurse, she is 95 pounds soaking wet. But she's type 2 diabetic because her genetics, everybody in her family has it. So she's an excellent candidate for a TZD, because these patients really don't see a significant weight gain from the medication. So again, more pictures. Just a quick mechanism of action about how this works. So the way this works is it essentially upregulates the GLUT4 transporter on the surface of the cell to increase insulin sensitivity and improve insulin and glucose transport into the cell. Because of the fact that it has PPAR gamma and PPAR alpha activity, we can also see some improvement in triglyceride levels because the PPAR alpha works on free fatty acid metabolism. Cons. So the average weight gain is about 3 to 4 kilograms, and that's over about a period of 5 years. But if you see, this was a study done that sort of says that the weight gain really is determined by a multitude of factors, including their baseline weight, combination of medications, diet control, and exercise compliance. So we do a lot of times like to use TZD in combination with metformin because that definitely offsets the weight gain that we see. And again, lower BMI patients are less likely to gain weight. This is contraindicated in class 3 and class 4 heart failure, as all of you know, due to increased fluid retention. It does cause lower extremity edema, and you want to be cautious in chronic kidney disease just due to the underlying potential for edema in that situation. This is not renally metabolized, so it is otherwise safe in chronic kidney disease. But as we know, a lot of our patients with diabetes and chronic kidney disease do have increased heart failure risks. I would just use that with caution there. Also, again, caution with cirrhosis due to the increased risk of hypoglycemia, not an absolute contraindication, but a discussion that you have to have with the patient, whereas a patient who does not have cirrhosis has very low risk for hypoglycemia on this medicine. All right, back again. Change it up a bit. Same patient, same A1C. Now, the GFR is 41%, and this patient has microalbuminuria. So what do we do first? So first, we want to adjust the metformin and reduce the dose, again, to 500 milligrams twice a day due to the fact that the GFR is 50%. Now, practically speaking, do we do that all the time in endocrinology? No, if the patient seems to be tolerating that well, if they're younger, where we're really not highly concerned about the risk for lactic acidosis, we may leave that dose at the 1,000 milligrams twice a day, whereas in an older patient where we're much more concerned about the potential for the lactic acidosis, we're more likely to reduce that. So what are our pros? I think I'm missing a slide here. So what we would pick here is the SGLT2s. Everybody knows about SGLT2 benefits to the kidney. It reduces progression of diabetic kidney disease, as well as chronic kidney disease with microalbuminuria that is not diabetically mediated. So there is both, an indication for SGLT2 for diabetes, but a secondary indication that can be used in chronic kidney disease without diabetes. So A1C reduction is between 0.4 and 1.1%. The reason that that's a little bit lower and a little bit more variable in terms of the studies is because the lower the GFR, remember this is inhibiting our glucose reabsorption, but if you have a decreased GFR, a decreased ability for that receptor to work in the first place, you are going to have decreased glucoseuria as the GFR declines. So you'll get a better renal benefit and a lower glycemic benefit. It also lowers blood pressure. So systolic blood pressure, about 8 to 10 millimeters per mercury. So you have a patient who comes into your office, maybe they're suboptimally controlled on their blood pressure, 140s systolic, and you're saying, well, okay, I can choose this medicine and not necessarily have to adjust your blood pressure medicine right now. Again, no risk of hypoglycemia. Weight loss associated with these medications can be between 2 and 3 kilograms. Slows the progression of chronic kidney disease and reduces coronary vascular risks in CHF. What's really important to know, too, about the chronic kidney disease piece as a practical point is it has to do with hyperfiltration, which is sort of a maladaptive response that happens in chronic kidney disease. But initially, when you start an SGLT2, you will actually see a slight decline in the GFR. And then what the difference is you'll see if you take the patient who's not on a GLP or a SGLT2 versus the patient who is, the SGLT2 will decline a little bit, but then stabilize. And the other patient will have a continual progression of their chronic kidney disease. That's important because if part of your discussion is, hey, I'm going to start you on this medicine for your sugars because it's also going to protect your kidney, and their GFR, when they come back, is 35%, they're going to say, I don't understand, doc. You told me this is going to help me with my kidney disease, and now my number's worse than it was before. So it is important to understand that that happens and coach and counsel patients ahead of time so they don't freak out, because everybody has their labs before we do now. So again, visual picture of how this works. And again, it's decreasing blood pressure. It's working as a diuretic. There are hemodynamic effects at the level of the heart and hemodynamic effects in the level of the kidney. And so all of these things are how we get not just glucose benefits, but cardiovascular and kidney benefit. Again, for trials, we've got a lot of trials specifically looking at this. The Credence trial, EMPA-REG trial, which looked at the cardiovascular risks. The DAPA-CKD trial, the DAPA-HF trial. The DAPA-CKD trial was a really nice trial because that trial really pushed the envelope and did it at much lower GFR levels. So really demonstrated that as low as 25% on the GFR is safe to initiate an SGLT2. And there are some additional trials being done to look even lower than that. Okay, so what are our cons here? Again, cost. These medications, you have to prior auth all the time. I have never had a problem successfully authorizing this medicine by giving the additive indication, whether it's heart failure, or they have a coronary artery disease diagnosis, or they have a stroke history, or they have chronic kidney disease with microalbuminuria. That doesn't mean that the out-of-pocket cost for the patient is going to be affordable. But there are definitely ways when the insurance company comes back to you and says, no, pick Actos, no, pick glipizide, that you can appeal and say, well, my patient has chronic kidney disease, multiple trials demonstrating benefit. They will approve it. Side effects, dehydration. This becomes really important for the patient that you're initiating this who's also on a diuretic. I do not routinely cut diuretic doses back on patients when I initiate these medications, but I do have a discussion with them about the importance of hydration and that they are higher risk. If you have that patient who openly admits that they're not good at drinking water and they may not be great at drinking water, this might not be the best choice for that patient. UTI, so urinary tract infections, vaginal candidiasis is one of the biggest side effects of these particular class of medications. We see it commonly. If a patient has a UTI, has vaginal candidiasis, I do not automatically stop the drug. If they've had recurrent vaginal candidiasis or UTI, I stop the drug. We do hold this prior to surgery, and we really hold it for two reasons. I did put specifically on here, if they're going to have an indwelling catheter, we already know right there they're going to have a 10% risk, but if they're on this medication, that risk goes up. The recommended guidelines are 3 days prior to surgery. I'll be honest, most of us will do it day before and day of. The recommendations are 3 days. The additional is particularly if they're going to be NPO, and then the stress of surgery increases the risk of diabetic ketoacidosis. Fournier's gangrene, I have actually seen a few cases of this, unfortunately. And I actually have a patient that I see for diabetes who had this prior to even, he had not been on this drug. And I was very nervous about, given his multiple history, he did have a coronary history, he did have a CKD history, and so I was really nervous about the nephrologist or the cardiologist putting him on an SGLT2, so I just added it to his allergy list and told him to add it to his pharmacy's allergy list, even though he'd never taken one, just to be sure he wouldn't get one. And then euglycemic DKA. So what we see in the hospital a lot is, patients seen in primary care, their A1C is 14, they're on metformin, and they get started on an SGLT2. They're a little glucose toxic at that point. The pancreas is already suboptimally producing insulin. So then adding this on board really definitely is a significant increase for DKA, and we see that frequently in the hospital setting. That becomes even more important in our Hispanic population as well as African American population because they're already known as type 2 diabetics to be ketosis prone. So I'm generally using an SGLT2 in a patient whose A1C is 8 or 9, not 11, 12, 13. I'll control them a little better first and then add it in. You also want to hold the medication when they're NPO for the same reason, the diabetic ketoacidosis risk. And then the ketogenic diet, right? So we're just talking how many patients are still doing Atkins or ketogenic or some form of ketogenic diet, not a safe diet for a patient on an SGLT2. All right, back to our case. So same scenario, cost is still an issue. What do we do now? Okay, so, well, what about a sulfonylurea, right? It's cheap. I can use that. And average A1C reduction's awesome, 1 to 1.6%, but again, higher A1C, you're more likely to see something closer to 2 and 2.5. Inexpensive, there's once, maybe twice daily dosing. This works by binding to the ATP sensitive potassium channel on the cell membrane, which increases insulin secretion. And therefore, of course, that sort of leads us into what's our main concerns. Hypoglycemia. And so in this particular case, this is our patient who has some chronic kidney disease as well. And the kidney clears both sulfonylurea as well as insulin. So now we're increasing our risk of hypoglycemia. So we have to be really cautious about dose adjusting for diminished GFR. I will also tell you a little pearl. Again, this is where sometimes the literature and the recommendations don't always line up with practicality. So every consult I have ever done on a patient in the hospital who had severely refractory hypoglycemia that took days to recover was a patient who had underlying chronic kidney disease who went into acute kidney injury on glimepiride. Right? And they say glimepiride sort of, it's a little bit longer acting, but it seems to be safer because the therapeutic distribution is more even. But you got that little old lady with a little bit of chronic kidney disease, not the right choice. Go with the glipizide in that particular case due to the shorter duration of action. This may also accelerate beta cell failure because it's stimulating pancreatic insulin secretion. So,
is there any time frame for that beta cell failure?
No, there hasn't been any study that significantly looks at is it 5 years, 10 years that I'm aware of. But we do know due to that increased stimulation that they do progress to insulin quicker. Now, again, if we're choosing this, it might be because we don't have a choice, right? We don't have a choice because our patient can't afford something we'd rather use in this situation. It's just understanding what the implications of our choices are. And if you have a choice in a younger patient with a thinner BMI between Actos and glipizide, you should be choosing Actos. Because I'll tell you that the patients, at this point in my career, the patients that I have who kind of do all the wrong things but still aren't on insulin 15 years later are all patients I have on TCDs. So they really do a very nice job of delaying disease progression. The weight gain, 4 to 5 pounds on average. Again, this can be mitigated if used in combination with metformin. All right, back again, changing it again. So now I'm going to change the patient completely. Now I have an 87-year-old female. Her A1C is 8.5%. She frequently skips meals. She has a normal GFR, no CAD or CHF, but she does have frequent UTI history. So what do you want to use? She's on metformin, which is fine. You can use metformin in an 87-year-old with a normal GFR. There's no issues there. I will caution, though, that patients can develop side effects as they get older. So you could see a patient who's 87 who's been on metformin for 25 years, who's presenting with diarrhea. They'll usually go see Dr. Kolnick first. They'll get the $1 million GI workup, and they'll come back, and I'll be like, did you stop your metformin? And they're like, no, I've been on it for like 25 years. I'm like, well, let's stop the metformin. 3 days later, my diarrhea is gone. So I helped put Dr. Kolnick's son through college. But, so just remember that people can develop side effects to medications as they get older or after they've been on them for a while just due to increased sensitivities. Okay, so what do we want to do now? So what about a DPP-4 inhibitor? All right, this is a once-a-day tablet, no hypoglycemia. You heard from the obesity team, this is a weight-neutral drug. Can be dose adjusted for the reduced GFR, although linagliptin does not require renal dose adjustment. Very favorable side effect profile, low risk of nausea. I refer to this drug as my little old lady drug because the little old lady that can't take anything tolerates this just fine. Downside, cost. So not so much in the realm of our GLPs and our SGLT2s, but again, with our Medicare patients, this one can unfortunately still be relatively costly. Also, it's a weak agent. Our overall A1C reduction is only about 0.6%. But right, this lady's 87 years old. I don't need an A1C of 6.5. I am perfectly content if she comes back the next time and she's at like 7.9%. You could argue you could leave her alone at 8.5%. But she has a history of frequent UTIs. So in this discussion, when I'll have with patients, when you're getting an A1C of 8.5, your average sugars are over 200, which means you're spilling sugar into the urine and therefore increasing her risk of UTI. So that's a patient I'm going to treat for the sake of reducing that risk. And this is my little old lady drug, and I love it in this population. Now, risk of CHF. So the data's been really back and forth on this issue. And if you review the literature, there's some studies that say, yes, there is an increased risk of CHF. No, there isn't an increased risk of CHF. So, I would say in a patient who's at high risk, I would probably avoid the medication. In a patient who has CKD, who maybe has significant edema, fluid retention, I might not want to use this medication. But just a consideration there. One thing I wanted to say about the sulfonylurea, this is for Dr. Alan Galley in the audience. There was a study done many years ago now that was called the Dagami study, and it actually was pre-SGLT2s and GLPs, so we didn't really have that, but specifically was looking at post-CABG patients and what medication was safe to use after CABG. And sulfonylureas did show an increased cardiovascular death risk compared to patients who were on metformin or on insulin. So if you do have a patient that you are seeing with underlying coronary disease who has recently undergone cardiac intervention with CABG, I might avoid a sulfonylurea. That being said, well, what do you do if they can't afford anything else? You may not have a choice. All right, back again. So now she's 87. She's still 8.5. She's still skipping meals. Her GFR is good. She still has the UTIs, but now she's in the donut hole and she can't afford the DPP-4. What are you going to do? So our short-acting secretagogues, I find these are sort of the most forgotten medications. And the reason, of course, is because they're, 3-time-a-day dosing, so it's a little bit inconvenient, but for your 87-year-old who frequently skips meals, this is a great choice. Average A1C, again, between 0.6 and 1%, not a home run, but she's 87, I don't want a home run. It's inexpensive. The shorter duration of action does decrease the risk of hypoglycemia, so you don't want to use the sulfonylurea in her because she's telling you she skips meals. So she has a high chance of having a low blood sugar. But with the short-acting secretagogues, you have a lower risk of that due to the shorter duration of action and her ability to dose that before the meal that she chooses to eat. And it helps with postprandial hyperglycemia. So for a patient that you have controlled on their fasting glucose, but they have rises in postprandial, this is another medication to consider in that situation. So it's, again, another potassium channel agonist, just like our sulfonylureas, but it is shorter action. Duration of action for this is about 4 hours. So the downside, it is dosed 3 times a day. So if you're going to use it specifically for postprandial control in a patient who isn't skipping meals and truly eats 3 meals a day, this may be difficult to remember. It does work best if you take it 30 minutes before meals, which, even with insulin dosing 15 minutes before meals is really hard to do. So I generally advise my patients that, if they have an opportunity to take it 15, 20 minutes before eating, great. If they don't, just take it right before they eat. You might, again, consider dose reduction in CKD. So repaglinide is actually stronger than nitaglonide, so I'm more likely to use nitaglonide if they have CKD. If I want closer to that 1% A1C reduction, I'm more likely to use repaglinide. Weight gain, also around 4 to 5 pounds. That, though, applies to the patient who's truly taking that at every meal. So our 87-year-old lady who's probably going to take it once a day, it's not going to matter. Back again. Now I'm going back to the 47-year-old. So now his A1C is 8%, his GFR is 41%, cost is an issue. We know he can't afford the DPP-4, he can't get the GLP, he can't get the SGLT2, and he has a history of hypoglycemia. Now what are you going to do? Alpha-glucosidase inhibitor. Like seriously, when's the last time any of you prescribed an alpha-glucosidase inhibitor? But it's cheap. It also delays progression of diabetes. And it helps with postprandial hyperglycemia. No risk of hypoglycemia. You can use it in CKD, you can use it in cirrhosis, and this is weight neutral. So again, underutilized in a time and an era where we have better drugs, but we can't afford better drugs. So, this is something where you just sort of remember that there are agents that can work effectively to improve glycemic control that might not be what you want to choose, but what you can choose. So this works at the brush border, and it works by decreasing glucose absorption at the brush border. I always tell my patients that this is not a spousal-friendly drug, and I always explain it to them by saying this is the opposite of Beano. So the major downside is really going to be the flatulence and the bloating. And it has to be dosed before meals. Average A1C reduction between 0.75 and 0.8. But again, now I made my guy's A1C 8%. So, I can get him relatively close to goal with that. And again, lifestyle modification is always part of this discussion. So I'll say to patients, listen, the average A1C reduction of this medication is about 0.7 to 0.8, that's not going to get you under 7 where I want you, so I need you to be more active and pull back on the carbs a little bit to try to make up the difference and get us where we need to be. Okay, when to add insulin? So any patient in DKA. And regardless of whether they're a type 2 in DKA and we're going to keep them on insulin long term, or they are a patient that has exceeded the laundry list of things that we can have them on, and we think it's going to be something, that we have to use. But a DKA, if I have we see many, and we did with COVID, saw a ton of DKA in the hospital, COVID-induced, because the virus actually directly infiltrates the islet cell. And so, we would say this is probably not going to be your forever choice, but because you had DKA, this is definitely our right now choice. Uncontrolled on multiple oral agents. So, you've got them on, because I always tell people, any combination of everything I just talked about is fine. There's a few things that don't make sense to do. So doing a DPP-4 with a GLP, it doesn't make any sense because you're kind of putting somebody on the big hammer. So giving them, the baby nail is, what's it really going to do? But it's safe to use all of those in combination. And I've done some cockamamie things to try to help patients, particularly patients who have a CDL, and they're like, I can't go on insulin, I'm going to lose my job. So I've had patients who've been on acarbose and Prandin and Actos, every combination under the sun just to keep them off of insulin. And you kind of know where the train's going, but you buy them as much time as you can. Side effects to multiple other agents, right? We have lots of patients that just, I got low blood sugars on my sulfonylurea. I got diarrhea on metformin. I got a UTI on the SGLT2. I vomited with the GLP, and then you're like, well, what else am I going to use? So, insulin. When oral medications are unaffordable, Dr. Bellotti and I were talking about at lunchtime, Walmart, thank you, Walmart, for making diabetes affordable. With their Rely On testing meter and the test strips that cost $9 for 50 strips, and their NPH and regular insulin that cost $25 a vial, and making it affordable for people to manage their diabetes. So sometimes the answer is not, I want to put you on insulin because that's my next step, but I want to put you on insulin because that's what you can afford. And I didn't mention it in the Actos talk, but I'll bring it up now. I had a patient that I saw this week, and I'd seen him a few months ago. He came into the office. He was maxed on metformin, maxed on GLP, can't afford medications. A1C was 7.4. We talked about adding another agent, and he's like, doc, let's just give me 3 months. I'll tune it up, and I'll get it in gear. Okay. So 3 months, comes back into me this week. A1C is 8.8. I'm like, well, that didn't work. So, yeah, right. So he's a 2-pack-a-day smoker. So I said, in terms of cost, with an 8.8, what do I have to choose from? And I talked about Actos. But in a trial done at the VA, there was an increased risk of bladder cancer associated with Actos. When that was done in other studies outside of the VA, we did not see that increased risk. The VA population does have higher tobacco use population, so really attributed to that. But so then it goes, do I really want to use Actos in a smoker, a 2-pack-a-day smoker? And he and I had this conversation, and I said, we can do that. Or other option would be to do NPH insulin twice a day. I don't want to do insulin, doc. I don't feel like drawing all that up and doing that twice a day. So we elected to put him on Actos. We'll do urinalysis to watch for RBCs and monitor. And of course, another conversation about smoking cessation and cutting back. But sometimes we're using insulin because it's just what we can afford. And then significant hyperglycemia, so new onset diabetes, A1C 10%, can consider insulin, although absolutely not necessary. What makes the difference? So if they're really symptomatic with the polys, you're probably going to want to put them on insulin. If they're coming in and they don't have any significant symptoms with that A1C of 10%, and they're telling you their diet's atrocious, so there's like a lot of wiggle room there, sometimes I'll start these people on metformin 1,000 twice a day, give them a glucometer, send them off to diabetic education, and they'll come back in and do swimmingly well. I had a patient that I saw in consult as a new patient. He had an A1C of, I think it was 10.5. He started on metformin, extended release 500. I almost laughed. I was like, what is that going to do? But he couldn't get in to see me for 3 months. So he'd already gone for education, changed his diet, 6.2%. So, so sometimes you can get away with less And this is why guidelines are guidelines. You know what I said to the residents? I just taught this similar lecture to the Rowan family practice residents. And so I'm starting to talk, and I talk about an A1C of 10, and they're like, well, doc, the guidelines. Well, the guidelines. And I was like, stop. They're not laws. They're guidelines, right? So yes, they are suggestions, but all of these other factors are really important to be considering when you're adding a medication. And I will say, like, I get to do this, and it's really easy for me because I say to the residents, I'm like, this all happens in 5 seconds in my head when I'm in the room with a patient, literally. And and I'll spit out and say, this is what I'm thinking, and this is what I'm thinking, and I thought this, and I thought that, and this is why I said yes, and this is why I said no, and I'll do it in 5 seconds. But I only have to worry about their diabetes. I don't care about their migraines. Did they get their pap smear? Did they have their mammogram? Like, you guys got a much harder job than we do in specialty care, and I applaud how much you have on your plates and how knowledgeable you are. But I do think, going back to my first slide, when we look at where diabetes is going, you actually have to be able to do this in the same 5 seconds that I do if we're going to be able to manage diabetes. So, summary, throw out your protocols. Great diabetes management is individualized just like A1C goals, right? We know that family practice was actually the first group to go away from an A1C of 6.5 to, no, I'm recommending individualized A1C goals depending on the patient. You guys did that before the endocrinologist jumped on board and agreed with you. So, but medication is the same way. Considering costs, side effects, the ability to adhere to the regimen, comorbid conditions. Most importantly, what are our ancillary benefits of the medications, including renal protection, cardiac protection, weight loss, et cetera. Of course, that's the most important, but frankly, cost is first, because at the end of the day, all of those ancillary benefits may not matter when cost becomes an issue. So I didn't really think we'd have a lot of time to talk extensively about insulin, but I'll just give you a quick, so how do you start new insulin dosing? So if it's a new insulin start, all insulin-based program, 0.6 unit per kilogram body weight, 2/3 long-acting, 1/3 short-acting, divided before each meal, right? You got a 350-pound patient, you put them on 10 units of insulin, they ain't gonna do squat, okay? So weight-based calculation. That goes out the window, though, if you have a patient on other oral agents. That calculation is for a truly, like the patient, they come in, they're like, doc, I can't afford my medicine anymore, and you say, well, I'm gonna send you to Walmart and put you on N&R because you can afford it. How do you calculate it? That's how you calculate it every time. Otherwise, I usually will say, do the same calculation, 0.6 unit per kilogram body weight, divide, 2/3 long-acting, reduce it by 50% as your starting point if they're on other agents. So same formula, keep it consistent. Obviously take into account if they have chronic kidney disease, it decreases insulin secretion. If they're old, lower dosing, and all of those things. But that's kind of the short and dirty of how we figure out insulin. That's all I got.
Thanks for including geriatrics. 87 seems young to me.
I will tell you I am doing a full endocrine in the elderly lecture for Rowan in September.
I'll be there.
So,
What to include in that talk is deprescribing. So deprescribing is a hot topic in geriatrics. So I have a patient on Jardiance and insulin. 92-year-old, everyone I get is inherited, so I don't know why they're on it, but they're now my patient forever. So what do I do with deprescribing? Leave them, their A1C is controlled. Thanks.
So, you bring up, I love that you brought up, 92-year-old on Jardiance, because, we see in endocrine now, the cardiologists and nephrologists, of course, are all sending us notes, start my patient on, an SGLT2 because they have chronic kidney disease. All right, well, is a 92-year-old more likely to wind up on dialysis or have urosepsis? Come on, people. Like, let's think about this. So So yeah, a 92-year-old on Jardiance would certainly make me nervous. I actually feel more comfortable having a 92-year-old on a basal insulin every day. So, my goal for the elderly population, I always tell them, is I want to keep your sugar under the point where you're not going to have symptoms. So generally under 200. If you're mostly under 200, you can back things off. In that particular case, I'd back the Jardiance off before I'd pull off the insulin, even though the concern is more for hypoglycemia with the insulin. I still think at that age, UTI, urosepsis would be more of a concern.
Steve.
Since a lot of your recommendations were based on the hemoglobin A1C values, I wonder if you could touch on two issues with it. One, normalizing it for, say, different races. People, I know there's some literature out there that in African Americans that were maybe using the wrong numbers. And then there's a significant part of the population that have various hemoglobinopathies, and how how do you address me? I know I wind up having to use fructosamines, but there's not great literature on that.
No, and even the conversion scales for fructosamine are not great when you're trying to say, well, if their fructosamine is 300, how does that translate into A1C? It's not really a great method. That is actually where I will use finger stick glucoses if I have a suspicion. So if I have a significant differential between what they present to me in their finger sticks and what I see on hemoglobin A1C, and this, to your point, from a racial standpoint is much more common to see in Hispanics and African Americans, I will rely more heavily on the finger stick once I can validate their meter with my own. So in the office, we'll do a finger stick, take that drop of blood, check it on theirs, check it on ours, and see how they correlate. Because some people have meters that are 15 years old, right? So then you're like, well, and then you do your meter and their meter, and there's a 100-point difference between the two, and then it's a meter issue. So that's how we count. The fructosamines we do use routinely, but they are tough to interpret. So I rely more heavily on finger sticking. And then CGMs are very helpful for our insulin-based population, but for our non-insulin population, getting the CGM approved is not easy, but we will sometimes in endocrine, which you guys can actually do too, is do a professional CGM. So I'll do a professional CGM, the finger stick, and the A1C, and sort of look where the data seems to find the most accuracy or consistency and rely on that.
Thank you.
Hi. The biggest barrier I have is getting patients to take injectables. Do you have a handout or some mechanism that you use? Do you have a special staff member that goes over them with you?
So when you say injectables, do you mean insulin or any of them? So I personally found that insulin, that was the case. There's a tremendous fear of insulin, and a lot of that has to do with historically people have associated insulin with the complications of diabetes. But I will tell you, when Byetta first came out, people would come to me, and the first thing they would say when I walked in the room was, I'm not taking insulin, I'm not injecting myself every day. And I would say, well, I have this medicine, it's a twice-a-day injection, but weight loss is associated with it. Sign me up, doc. I mean, I really haven't had issues with injectables when I attach weight loss to it. But we show them the needle size, our nurse shows them the needle size, you can barely see it, it's like a hair. And I always tell them, it's a lot more comfortable to inject anything we give you than it is to do a finger stick. So if you can finger stick yourself, you can inject. And I think specifically for insulin, it's the fear of insulin that people have.
And a second question I have, can you talk a little bit about fructose, why endocrinologists always order fructose?
The fructosamine. So fructosamine is a 2-week blood sugar average that is not measured on the hemoglobin molecule. So if you have a patient who has a hemoglobinopathy, like our last doctor just talked about, or if they have chronic kidney disease and have significant anemia or recent blood loss, and you question the reliability, because I'll have some patients who will come in and they'll give me glucose labs, and all their sugars are above 200, but their A1C is 6.5. You know right then and there that A1C is not right, but the fructosamine in that situation may help clarify that it's truly a hemoglobin issue.
Doctor? Yes.
It's getting noisy back there, so I had
Oh.
to come up here.
Excuse me, 1 second. I'm sorry. Folks in the back, if you could, just to let you know, there's coffee and refreshments, so rather sit back there and talk. If you want to go quietly, you can get some refreshments while we continue answering questions. We're not going to have a break in lecture, so our next lecture is going to start immediately following this at 4 p.m. So, Dr.
have time for one
Yep.
more?
Yep.
Thank you for an excellent lecture.
Thank you.
Very soup to nuts and very, very concise. I practice bariatric medicine and see diabetics every day who are sent to me for fix their diet, and they all say to me, get me off of everything you can, doc, and that's my goal, deprescribing, like Dr. Overbeck mentioned. Can you comment on the use of intermittent fasting, anything that you can give us in that way? Because I do use it and I've had very good results with it, but I'm interested in your feedback. Thank you.
So interestingly, intermittent fasting, of course, from a diabetic management standpoint, any agent that causes hypoglycemia is going to be a risk in that setting. So those are medications where you may reduce everything by 25%, 50% if it's a sulfonylurea, 25% if it's insulin, just to reduce the chances of hypoglycemia, with the caveat that you can always up-titrate it again very easily, but I'd rather go in lower and up-titrate than have them get low.
Oh, yeah, absolutely.
There's multiple types of intermittent fasting, but interestingly, a lot of my patients do the skip breakfast, but the data was actually studied the opposite. It was cutting off in mid-afternoon and going extended periods in the evening. In those cases, from a medication standpoint, if you're using a sulfonylurea, is a little safer because you can dose that in the morning. It's running off and tailing off at the end of the day, and they have lower risk that way. The other where there's data is every third day or fourth day, calorie restricting significantly.
Yes.
So in those cases, if they're on insulin, I might say on day 3, reduce by 50%, hold your sulfonylurea, and then that's a way where it defeats the purpose. If you have to eat to bring your sugar up, it defeats the entire point of what you're doing. So that's how I manage it.
Thank you.
Thank
Very
you.
good.